I ask Carlos Rodriguez-Galindo to give us an overview on on sarcomas and common diagnostics and treatment. So enjoy the talk.
Thank you so much, Mr. Chairman, and thank you everyone for coming so early for this session. So I realized that I am in a sandwich between neuroblastoma talks, so I will try to concentrate as much as possible what I think are important topics for sarcomas. But sarcomas is a very broad topic itself, so I've tried to go over a few concepts, just highlights on what I think has been important to remark in the last few years in Ewing sarcoma, in rhabdomyosarcoma, and in osteosarcoma. And so we'll start with Ewing sarcoma, and I will try to highlight 2 points. One is how the treatment has evolved in the United States towards what we call dose-compressed therapy. And then we'll talk a little bit about new therapies, particularly biology-driven therapies, and we'll take the opportunity to highlight the advances in our knowledge of Ewing sarcoma. So you are probably familiar with this trial, which was the AEWS 0031 that studied in a randomized manner treatment with the standard alternating cycles of increased doxorubicin and cyclophosphamide with ifosfamide and etoposide, which has been, as you know, the North American or the COG approach to the management of Ewing sarcoma. And the randomization was between 3-week cycles or 2-week intervals. So 3 to 2, exactly the same doses of all agents. And as you know, these studies were published already, but what was remarkable is that the dose-compressed arm showed a significantly improved event-free survival and overall survival compared with the standard 3-week intervals. So with the dose-compressed arm, the 5-year event-free survival was 73%, and overall survival was 83%. Remember, this is just for non-metastatic Ewing sarcoma. And for the every 3-week cycles was 65% and 77% respectively. So since then, the treatment in North America or in COG institutions has been changed to dose-compressed therapy. So what other drugs are coming down the pipeline? So not so many. In standard combinations, we have the topoisomerase 1 inhibitors, as you know, and gemcitabine and docetaxel, not so good. Then we'll talk about some new molecular targets. So for topoisomerase inhibitors in Ewing sarcoma, you know there are 2 main combinations. One is cyclophosphamide with topotecan, the other one is irinotecan with temozolomide. The cyclophosphamide topotecan regimen has been well known for quite a while, and this is now part of the new randomized clinical trial, which alternates VDC and IE with or without cyclophosphamide and topotecan, as well in a dose-compressed manner. The other combination, so this combination in general can induce responses in up to 1/3 to 50% of patients with relapse disease. So the other very popular combination, as you know, is irinotecan and temozolomide, which also leads to responses close to 30 or 50% in patients with relapse disease, probably higher in patients that have not received therapy previously. This combination is still used for salvage treatment, has not been moved to the front line. And then just because it has become very popular to use gemcitabine and docetaxel for sarcomas, I thought about highlighting this. Because really for Ewing sarcomas, I don't think that we have any strong evidence that this combination works at all. So there have been several papers over the last few years looking at this combination for osteo, Ewings, and other sarcomas, and I just highlight here in the 3 papers the responses seen in Ewing sarcoma. so around 14% in the first paper, a few more responses in a paper from Barcelona in Spain, but then in a much larger study the responses were not so clearly documented. So it's an option for patients with relapsed disease, but not a combination that is ready to move to frontline. And then we'll talk about new molecular targets. So I highlight two of those, anti-IGF-1 and PARP inhibitors, among some others that are being investigated as well, but for which we don't have time today. So I will start with one of those anti-IGF-1 monoclonal antibodies for Ewing sarcoma. There have been 3 phase 2 studies, of which 2 I will show here. One was the Roche antibody, as you know, was published already a few years ago. So this study showed response rates of approximately 10%, 15% if you count all the patients with minimal response. So you have 1 patient with complete response, 10 patients with partial response. So for a new agent, a 10% or 13% is not a great response, but considering that it's a biology-driven therapy, I think it's worth considering. Particularly when you look not only at the RECIST criteria responses. So for RECIST criteria, we have 13-15% of responses. But if you calculate or if you look at any type of response, any patient showing some sign of biological activity, close to 1/3 of patients actually have some degree of response, which is remarkable. So this is one example published in that paper of 2 patients with large, relapsed lesions in the chest, both of them, and how after anti-IGF-1 these lesions responded quite significantly. However, this did not seem to impact outcome, and probably that's expected as well as a single biology agent. So the outcome was still very poor after relapse of Ewing sarcoma. And then I just show here another, the second study that was followed by Dr. Jurgens, and that showed basically the same. Response rates of around 14%. Again, no long-term improvement on long-term outcome, but it's around 14% as well. So these are good enough, I would say, for a biology-driven therapy that now COG has a randomized clinical trial for patients with metastatic Ewing sarcoma that basically randomizes patients to the standard dose compressed therapy with or without anti-IGF-1 monoclonal antibody that is given on day 1 of each one of those cycles. So hopefully in the next maybe 5 years we will know what is the outcome of this trial. And then this is the original description of Ewing sarcoma by Dr. Ewing, published in his book of neoplastic disease 1919. And that's how Ewing sarcoma was described. At the beginning was the endothelioma of bone, and that would be the first drawing of a small round blue cell tumor, I would say. I just show that because it's been 100 years almost, and now we have moved quite a bit in Ewing sarcoma. So for many other sarcomas, we talk about the omic era, the genomic, proteomic era. So that has led to major advances, I would say, in many sarcomas, at least in our knowledge. I highlight here 2 papers that were published in the same issue of Cancer Discovery a couple of years ago, or less than that, and that highlighted very interesting findings for Ewing sarcoma. First, that Ewing sarcomas, many translocation-associated malignancies, have a very low number of single nucleotide and structural variants. But interestingly, in one of those papers, it was shown that some gain and loss of chromosomes 1 and 16 are associated with worse prognosis, and it's very clearly associated with worse prognosis, so it's important to consider that in the future for risk stratification. And then that these single nucleotide variants and structural variants, the number of those or the rate of those, are associated as well with survival and particularly with age. Older patients have a much more disturbed genome. The most frequent coding variants occur in STAC2 and P53, and also in some epigenetic regulators. And then STAC2 and CDK and 2A genetic lesions are mutually exclusive, but they are quite prevalent, around 15 or 20% of the tumors. And then usually when you combine STAC2 alterations with P53 alterations, which are actually always coexistent, the tumors are much more aggressive. So I think the bottom line of this is that we have learned a little bit more the behavior of Ewing sarcoma tumors, and hopefully we'll have a few new ideas to use for risk stratification in the future. So as far as new agents, the next one we're going to talk is about PARP inhibitors. So PARP inhibitors have now been popularized particularly in patients with BRCA deficient malignancies. So there have been responses in close to 1/3 or more of patients with ovarian or breast cancer. And I show here one interesting article that looked at the use of PARP inhibitors in patients with Ewing sarcoma, in mice with Ewing sarcoma. So this is a true xenograft orthotopic model where you can see that the tumors are generated by injecting Ewing sarcoma into the femur of the mouse, and that generates a real tumor, as you can see here, even by PET scan. So it's a true, quote-unquote, true Ewing sarcoma in the mouse. And this is what we could equal to a phase 1 study in mice. So phase 1 study combining in the top panel PARP inhibitors alone with temozolomide, with irinotecan, or with both. So that is PARP inhibitor plus irinotecan plus temozolomide, and do a few dose response curves just to optimize the dose. And you can see that, yes, definitely there is a good response, and I just show it here in the combination of a PARP inhibitor with irinotecan and temozolomide, and you see how these mice respond. So this is a phase 1. Phase 1 is dose finding for these combinations. So this is a true phase 3 trial in animals, that is cohorts of mice with Ewing sarcoma randomized to different arms. And so I will highlight here how the combination of PARP inhibitors with chemotherapy induces long-term survivals in these mice with Ewing sarcoma, and you see that here again in these mice. But just keep in mind, in this figure, this would be the equivalent of a clinical trial. So for those of you that are interested in reading a little bit more, there is an interesting article that was published recently that highlights some of the potential avenues for therapy. So in conclusion, for Ewing sarcoma, 2/3 of Ewing sarcoma patients can achieve a long-term survival. The outcome is relatively influenced by treatment intensity. Risk stratification models are possible, particularly with the new developments in our knowledge of biology of these diseases, and that also there are new avenues for therapy, particularly a combination of PARP inhibitors with the standard agents. So the next, and we'll go quick over this, the next disease that we want to touch is rhabdomyosarcoma, and we'll touch on just 3 concepts. One is fusion status and biology, then is VAC still the standard in North America, and then mTOR inhibition for relapsed rhabdomyosarcoma. So as you know, for rhabdomyosarcoma, the most important prognostic factor is in biology is histology, embryonal versus alveolar, and alveolars are defined by the presence of a fusion transcript, as you know. So it's PAX3 or PAX7 with 4-ker, so that is the 2 different translocations, 113 or 213. The question is that about embryonal or alveolar, or is this about fusion yes or fusion no? And that is because there is a group of patients with alveolar rhabdomyosarcoma that do not have a fusion, and yet we still call them alveolars. So when you do that, and there is this paper that came from several studies in Europe, when you put all the fusion-negative rhabdomyosarcomas in blue, and you split them from the fusion-positive rhabdomyosarcomas, you see that the fusion-negative tend to cluster with the embryonal rhabdomyosarcomas. So fusion-negative rhabdomyosarcoma probably behaves like an embryonal rhabdomyosarcoma. This was also tested in a COG cohort of intermediate risk rhabdomyosarcoma, and you see basically the same. Fusion-negative rhabdomyosarcoma is as good, if not better, than embryonal rhabdomyosarcoma, and then you have the two types of translocations, the 7 and the 3. So when you then look at the different arms within a trial, different subgroups, you see that the fusion-negative rhabdomyosarcoma performs very well in the entire trial, and by different subgroups, it performs as good, if not better, as embryonal rhabdomyosarcoma. So the question is fusion-negative versus fusion-positive, and I think that we will start switching to that concept rather than alveolar and embryonal. And the fusion-negative, is this just one type of disease? Probably not. There was an interesting paper looking at gene expression profiling of the gene expression signature of fusion-negative rhabdomyosarcoma. There is a signature that they call MGS signature, a cluster of genes that were differential. And when you look at this cluster of genes, you have the fusion-negative rhabdomyosarcomas that are actually positive or negative for this gene expression signature. And you can see again that there is a further splitting of these two categories. So for rhabdomyosarcoma, again, we have learned from next generation sequencing, embryonal rhabdomyosarcomas are very rich in mutations. The mutational rate is very high, much higher than for alveolar rhabdomyosarcomas. And the bottom line is that the cancer consensus gene mutations are pretty high in rhabdomyosarcomas. 88% of high risk, 73% of intermediate risk, and 20% of low risk rhabdomyosarcomas have mutations, particularly in the RAS pathway, and that's the pathway that we need to consider for further target therapies. Then just one quick comment on therapy for these patients. The intermediate risk rhabdomyosarcoma, as you know, is defined by localized alveolar or fusion-positive rhabdomyosarcomas and then advanced embryonal rhabdomyosarcomas. So the trial that I'm highlighting here, the 531, randomized patients to VAC versus VAC alternated with VI, vincristine and irinotecan. And that's basically how the trial was. As you know, in the United States, VAC is the gold standard for intermediate risk rhabdomyosarcoma. The outcome was exactly the same. The addition of vincristine and irinotecan did not improve outcome. However, the addition of vincristine and irinotecan decreased toxicity because it's a much less toxic combination. So even though it did not improve the outcome, it resulted in less hospitalization, less use of growth factor, and similar otherwise adverse events. And so since then, VAC-VI is the new gold standard or standard for intermediate risk rhabdomyosarcoma in COG. After 30 years, probably, we have moved from VAC to VAC-VI. It's less toxic and cheaper than VAC. And the final thought is about survival after relapse. As you know, it's very difficult to salvage a patient with rhabdomyosarcoma after the patient has relapsed, and really we do not have good therapies. So because most of these patients relapse after having had irinotecan in the United States or North America, we have explored the use of vinorelbine and cyclophosphamide, which is much more popular in Europe. There are several studies, particularly from Italy as well as in the US, showing that responses to vinorelbine cyclophosphamide can be as high as 50% in relapsed rhabdomyosarcoma. In addition to that, there is evidence that both mTOR inhibition or anti-angiogenic approaches may induce responses in rhabdomyosarcoma, and this led to this randomized clinical trial for patients with relapsed rhabdo that compared vinorelbine cyclophosphamide plus minus bevacizumab in one arm here, or temsirolimus on the other arm, which is an mTOR inhibitor. This trial actually had to stop early in July of 2013 because one arm, that is group B, which is the one with temsirolimus, was outperforming arm A. So therefore, since then, the salvage treatment that is considered the standard is vinorelbine cyclophosphamide and temsirolimus, but that actually also shows that temsirolimus or mTOR inhibition can induce responses in Ewing sarcoma, in rhabdomyosarcoma. So it's a valid agent to be used for relapsed rhabdomyosarcoma. So in summary, for rhabdo, the fusion status and gene signature predict outcome and will help with risk stratification in future trials. We're doing risk-adapted therapies for low risk, intermediate risk, where the VAC VI is now the new standard, and probably fusion status will aid in better definition. And then we'll move quickly over the last topic in the last 3 minutes, which is osteosarcoma, as you know. So there is not that much to tell about osteosarcoma, as you very well know, but we'll talk a little bit about the genomic landscape, and then whether or not we need to modify treatment based on histologic response. So this is again the genomic landscape of osteosarcoma, much more disturbed genome, much higher mutational rate, similar to what we saw for embryonal rhabdomyosarcoma. So it's a very disturbed genome. So I will not show all the particular data. I will summarize here what these 2 articles show that were published a little bit less than 2 years ago. First, that osteosarcoma has this hypermutation status that we call categories, and that's more than 50% of the tumors have this hypermutational state. They have median of 230 somatic rearrangement per tumor, much more than we have seen in other pediatric solid tumors. But we see very frequently very typical mutations that seem to be recurrent. All tumors have alterations in the p53 pathway, and the majority of tumors have alterations in the RB1, ATRX pathways in up to 50%. But when we cluster all these alterations into pathways, there is a pathway that appears to be central, which is the PI3 kinase mTOR pathway, that seems to be the most vulnerable for osteosarcoma. And when we do studies in vitro, inhibition of this pathway seems to show sensitivity in osteosarcoma cell lines. So we need to start thinking about how to maximize this information and target this pathway. And unfortunately for treatment, and you can see here what has happened over the last 30 or 40 years in osteosarcoma, we have reached a plateau after the 1980s when methotrexate, erythromycin, cisplatin were established as the standard regimens. So that was the first randomized clinical trial in the 1980s, and now basically the event-free survival curve 30 or 40 years later is exactly the same. So we have really not advanced much, but what we know, and that has been our main battlefield, is that the histologic response after neoadjuvant chemotherapy is one of the most important prognostic indicators, as you see in this slide, that also stratifies by age. But the bottom line is that histologic response remains a very important prognostic factor. And so the question has been, you treat all these patients with 3 drugs, methotrexate, erythromycin, and cisplatin, you do surgery, you look at the histology, and then what do you do? Do you continue with the same agents, or should we change? And that's basically the big question after 30 years for osteosarcoma, and that's what the EURAMOS study tried to address. And the EURAMOS basically put together multiple clinical research organizations and cooperative groups from all over the world, and basically randomized patients with good histologic response in the top to receive or not interferon, and patients with poor histologic response to have ifosfamide and etoposide on top of MAP. And so this is just the first stratum, the interferon stratum. You see that it's difficult to randomize these patients. It has been a very slow trial to accrue. And this was published already by Dr. Bilak. I will go very quickly over this. Just highlight that randomizing these patients is very difficult. 2/3 of the patients accepted randomization, but even those that accepted randomization, 75% of the patients started interferon. So the numbers keep dropping, and that's why it has taken so many years. Bottom line is that the number of events on both arms were very similar, and the outcome was almost identical, 77 versus 74%. So the bottom line is that interferon, the addition of interferon for good histologic responders, doesn't seem to be so beneficial. And then for poor histologic responses, this randomized clinical trial was even more difficult to conduct because you had randomization that occurred after surgery as well in patients with a lot of toxicity. Nevertheless, this trial was completed as well, more than 1,000 patients enrolled. Bottom line, the outcome is exactly the same. So the 3-year event-free survival for MAP or MAP-IE is around 52-54%. So the question has been answered, so that is the addition of ifosfamide and etoposide for poor histologic responders is not beneficial. And finally, this big question in the United States, not so much in Europe apparently, is what to do with muramyl tripeptide. We know that osteosarcoma fails usually because of lung metastases, and that MTPPE can induce macrophage activation, liposomal formulation distributed in the lungs, and that might be an effective way to treat lung metastases. So this was also a very complicated trial because it had a double randomization to MAP therapy plus minus ifosfamide and plus minus MTPPE. As you know, this was published a number of years ago. And the results have been very confusing because there seems to be an interaction between mifepristone and ifosfamide. So in the long-term review or evaluation of this trial, there appears to be a benefit towards the use of MTPPE in these patients. This data has been good enough for the EMEA in Europe to approve this drug, but the FDA in the United States has not approved this drug. So even though we think that it might work, there are not enough data and it hasn't been approved, so it will be difficult to test this agent. So finally, what other drugs are for osteosarcoma? We talked about IGF-1 receptor for Ewing's and for other sarcomas. So there could be a potential for osteosarcoma. Also c-Met inhibition, because c-Met is expressed in 60% of osteosarcomas. HER2 has been tried, doesn't seem to be working. Esrin has also been tried recently, and the trial was a failure. And others, particularly anti-GD2, that is also expressed in osteosarcoma. And then because of the high mutational rate in osteosarcoma, there is a high rate of neoantigen formation. So there is also a thought that checkpoint inhibitors like anti-PD-1 could also be beneficial. So to summarize, osteosarcoma has a very complex genomic landscape. I'm sorry I'm running out of time. A high mutational rate and recurring alterations. We have this PI3 kinase as a vulnerable pathway. We have not really advanced too much in treatment, but MAP remains the standard of care, and treatment modification after surgery is not beneficial, and that new treatments are currently being explored. Thank you very much.
Thank you very much. Fantastic. It's already 10 minutes over. So.